Okay, I might be a little bit off because I edited the PowerPoint for another presentation and I'm looking at that, but I'll try to. So why don't you go to the first slide, just see my introductory slide. I'm Michael Portman from Seattle Children's. And today we're going to talk about COVID vaccine in general and in congenital heart disease. So the first slide shows what's actually happening as far as December 4th, 2021, with respect to COVID in the United States. So this is a rolling graph that shows the incidence of COVID. And if you look at the olive stripes, the lighter green stripes, that's what is happening in children as far as caseload with COVID. So you can see that there was a dramatic peak in pediatric COVID cases at 0 to 4, 5 to 11, and 12 to 15 in September of 2021. So you will see that that goes from almost a very, very low incidence to the pediatric age group, that's 12 and over, having more cases per capita than any other age group in the United States. So if we go to the next slide, we need to decide what is the risk of this increase in COVID in the pediatric population with respect to congenital heart disease. So there's been quite a bit of speculation, and much of it was done early during the COVID pandemic. Here is a paper that was published in the Journal of American Heart Association in May 2020. So this was right after the COVID pandemic had really taken root in the United States and across the world. So this paper is basically an opinion paper. And some cardiologists speculated about what could be the potential risk to pediatric and adult congenital heart disease. Now, the reasoning they had it, if you can go to, I'm sorry, can you go to the next slide? Yes. So in the opinion paper, here's the reasons they thought that COVID-19 and SARS-CoV-2 was going to be important, because it had a very high mortality and morbidity in adult patients with acquired heart disease, that the virus itself may, and in fact does, impact the cardiovascular system. And the viral disease may cause symptoms that mimic those of cardiovascular disease, like cyanosis. Cardiac care team members are at risk for acquiring COVID and play a role in spreading the disease. But most importantly, patients with congenital heart disease are known to have higher risk for complications with viral illness. Now, I will say that that is mainly, not yet, back up. That is mainly from certain viruses that we all know cause complications in CHD, particularly among children, influenza and RSV among those. The other issue was that COVID-19, as it expanded, could stretch our health care system, and our resources may be limited to take care of our children with cardiovascular disease. And in fact, even in our own center, many surgeries were postponed or canceled. Many catheterizations were postponed. So at least in that time period, last late spring and summer, it did in fact have the impact. However, the other issues related to COVID, some of them have become partially true and some of them haven't become true at all. So let's go on to the next. So I looked at the literature and what good literature has been published looking at the risk of COVID-19 with patients with congenital heart disease. The best literature that I found was a paper in the Journal of American College of Cardiology. Now, this really focused on adults with congenital heart disease. Basically, what they found was that the risk and severity of the disease, if you looked at this entire stretch of congenital heart disease and all the diagnoses that we have limited, put them all together, that the risk is actually no greater than the risk in the general population. However, there were certain factors that did give you increased risk, and you can kind of guess what those are. Those are patients who are cyanotic, patients who have Eisenmenger syndrome, patients with pulmonary heart hypertension. There are some with congenitally corrected TGA, but remember, these are adult patients, and patients with transposition, these would be very older patients who had had atrial switch operations, which we don't do anymore. Down the road a little bit, you can see the Fontan physiology. They had 118 patients with slightly increased risk of mortality and slightly increased risk of severe disease than the general unaffected population with cardiovascular disease. So it really wasn't a substantial increased risk in those types of patients. So let's go on to the next slide. So what do we have in children? And there was this paper that was recently published in Pediatric Cardiology. It says worst hospital outcomes for children and adults with COVID-19 and congenital heart disease. So for the purpose of this talk, I just restricted it to the population that was less than 18 years old. So what they did here was they took an administrative database from hospital admissions and looked at outcomes from the administrative database. So they looked at mortality, they looked at complications, which I'm not really sure how they extracted that from the database, and they were able to get some financial information. So what they found basically was that the children under 18 years of old with congenital heart disease had a worse outcome, meaning very slightly greater mortality. And as you can see, there are only 6 cases out of 160 that died. And that was greater than comparison with the no CHD population that was admitted for COVID. But you can see that that N number of patients is substantially larger with 9,318. So they did look at significance and found that despite the very low numbers in congenital heart disease population, these were significant to a level of less than 0.001. Now let's go on to the next slide. So I sort of had a problem with this study because I looked at our own administrative database at Seattle Children's. And what we did was we have a way to access our clinical information depository, and we can run search terms. Now in that administrative database that had come from the University of Arizona and the data that I'd shown you on the previous slide, they basically focused on ICD-9 codes. And that is also what our database does at Seattle Children's. So what I found was that many of the cases of COVID that we picked up really weren't even sick. They were patients who often were admitted on an elective basis for procedures over the past several months or for some other reason, and they happened to get a screening test and were found to be COVID positive. So basically, they were comparing not with patients who actually had COVID disease, but with patients that, for whatever reason, had a serendipitous COVID test. So that would affect the data in showing that and strengthen the finding that children with congenital heart disease had more severe disease. So if you go on to the next slide. Okay, that's pretty much what I have as far as the effect of COVID on the population with congenital heart disease. So the other issue that we have with COVID is multi-system inflammatory syndrome in children. So this is a syndrome that affects multiple systems, often the cardiovascular system, the heart directly in about 30 to 40% of the cases, where the patients have functional abnormalities by echocardiogram. They often are hypotensive, and they almost always need admission into the intensive care unit for whatever specific syndrome and system is causing them problems. And oftentimes it's not the heart. Oftentimes, they're hypotensive because of vascular instability and not necessarily due to a decrease in cardiac function. So in the United States, since about April of last year, there have been 6,000 cases in the United States, and there's only been 50 deaths. That gives a pretty low case rate of about 0.1%, case fatality rate, I should say. Now, having said that, the caveat is that in the beginning of the pandemic, we really had no clue how to treat this MIS-C. Many patients would develop thromboses. There were some patients that had to get put on ECMO. We found out later that they needed anticoagulation to prevent some of the complications. So I suspect that most of these 50 deaths were in the beginning, the first few months of this syndrome. In this slide, you can see the numbers as they're spread across the United States. And this is not per capita, this is just number of cases. And you can see that kind of the most populous cases have, the most populous states have the most cases. That goes certainly for New York and California, Texas. I'm not really sure why Georgia has such a high incidence rate. You think that Illinois would have higher. So it's somewhat sporadic. I would say in Washington State, we have not been afflicted with this syndrome as much as other states. And if you go to the next slide, here's what's happening with COVID across the United States, as this is a 7-day moving average reported by the CDC. So the MIS-C cases generally appear somewhere between 3 to 4 weeks. The peak is after the peak incidence of COVID in your particular region. Here, it generalizes for the United States, but for instance, in Seattle, we had the Delta wave that occurred in about September and October, and just a couple weeks after that, we started seeing more cases of MIS-C. There was some time during the summer where we had no cases admitted of MIS-C. So we believe it's similar to Kawasaki disease in that there is some sort of, well, there is a viral infection. In this case, we know what virus it is. It's SARS-CoV-2. And then the child gets infected, and then subsequently, at about 3 to 4 weeks later, sometimes a little shorter than that, a patient will have a hyperimmune response that leads to MIS-C. And if you can go to the next slide. Here's what's happened in Washington State. I extracted this from our own state's database. It's a little bit odd. You could, in blue is what happened in the year 2000, and in orange, you can see what happened in 2021. And as I said, if you look at September of 2021, that peak incidence in MIS-C in Washington State occurred just shortly, maybe 2 to 4 weeks after the peak incidence of the Delta variant in Washington State. So if you can go to the next slide. So in sum, if you can compare what's going on, that we've had about 30 patients with acute COVID pneumonia admitted to Seattle Children's. And then we've had a little bit more, 40 cases of MIS-C. But in all, they're not overwhelming numbers. Some of the centers on the East Coast are reporting virtually a couple hundred cases. In particular, Washington National has quite a few cases, and Atlanta Healthcare in Georgia also has a substantial number of cases. So I really can't say why Washington State, it might be related to our vaccination rate, but why we're not as affected as some of the other large cities in the United States. If you go on to the next slide. Okay, so the National Institutes of Health has responded with some surveillance and observational studies. The largest one is called the COVID Music Study for long-term outcomes after multisystem inflammatory syndrome in children. And the little pinpoints on the map show the many centers, which includes Seattle, several centers in New York, Washington, DC, Michigan, Cincinnati, and also Toronto, which is part of the Pediatric Heart Network, the only Canadian center. So the music study has now enrolled over 1,000 children, and we're concerned of, number one, how do we diagnose MIS-C? What sort of symptoms do these children have? And most important, what is the long-term outcome after multisystem inflammatory syndrome in children? I will say in our local experience, number one, I don't think that we have many patients with who have had pre-existing heart disease. The vast majority of these are previously healthy children. I believe 1 or 2 children with Down syndrome have been admitted with MIS-C, or sometimes it's difficult because of timing to separate MIS-C from a direct COVID infection. So we do have 1 or 2 children with congenital heart disease, but certainly not a substantial number, and we have not had any terrible outcomes. Most of the children do have resolution, but we still are not certain what the long-term outcome is. So far in the population of patients that I follow, everyone's been doing well. They've recovered and are doing in general well, but we're doing surveys and we're doing some echo studies over long-term. We have a 5-year plan to look at these children. So if you go to the next slide. Okay, so now the discussion is what's going on with vaccination. Doesn't it have any effect at all on reducing the incidence of MIS-C and direct COVID infection? So if you go to the next slide. So in this slide, it's a little bit scary because it's looking at the case numbers. And I showed this slide before just so we can do a comparison with what's happening with the vaccination group. So if you go to the next slide. Okay, so in the top slide, this is showing vaccination status by hospitalization. So these are hospitalized patients for COVID and what's happened. In the green, you can see the hospitalization rate for vaccinated patients. And in the blue, it's fairly obvious that there's a peak, especially in the past few months, for patients who are not vaccinated. So it's pretty substantial. If you look at the scale, this is per 100,000 population, and the scale is up to about 60 per 100,000 are admitted daily for COVID infection. Now, if you look at the lower, this is for what they have data for, hospitalization data. This is for age 12 to 17 years. Who's getting hospitalized? So your immediate reaction, if you're looking at this, is, wow, that is a really big jump. And if you listen to the media, they're telling you, oh yes, there's like 2,000, 3,000% increase of unvaccinated children over vaccinated who are getting hospitalized. But if you really pay attention to the scale of what's going on in these graphs, notice that the top of the scale is 4, while for the adults, the top of the scale is 60. So it's really, yeah, you could say there's 3,000 or 4,000, but in actual numbers, those are not huge for children who are unvaccinated being hospitalized. So if you go to the next slide, we're doing the same as far as COVID deaths. So in the upper left-hand corner, you can see the in the dotted, there is patients who are unvaccinated for each age group. And in the solid colors, which are kind of buried near 0, are the vaccinated. So obviously for the adults, there's a big, big difference in vaccinated patients versus unvaccinated as far as deaths go. But buried in that little bottom hump near September 2021 is the data for the pediatric age groups. Since there's only about a few deaths in children in the United States, you really can't see that data in that curve on the left. And in fact, the CDC doesn't offer a chart for showing the pediatric age groups as far as death. The youngest age group that I have is for the 18 to 29-year-olds. So again, in the right lower, you see the green solid is vaccinated patients versus the dotted, which is unvaccinated. And sure, it looks like there's a big jump, but in absolute numbers, that scale is 0.8 at the peak compared to 100 for the scale for the older patients. So it's still very, very tiny. Hardly any COVID deaths reported to the CDC by whether vaccinated or unvaccinated in the younger age groups. So if you can go to the next slide. In Washington State, what's happening with vaccination? So as of, I believe this was December 1st, and that was about a week or two after approval for the younger age group, only about 20% of the population had initiated vaccination in the age group 5 to 11. There's only 2.81% that have gotten fully vaccinated. I'm sure that that's an increased, although I've heard that it's right now availability for booster shot, availability for the second shot with the pediatric age dosing is not, it's not that easy to schedule your child. But still, if you look at, in the first couple of weeks, it seems that parents are a little bit hesitating to get their children vaccinated. Now, one of the reasons for that is we can go back to the Pfizer study for which they got emergency authorization for vaccination. In fact, in that study, that was 2,400 children, and it was a 2-to-1 randomization. So only about 1,600 children actually got the vaccine in that study. So it's a pretty small study to show safety. If you go to the next slide. So the major side effect that we have seen for the vaccine is myocarditis or myopericarditis. We've had 27 cases at Seattle Children's. Now, all those cases were 12 years old and above. We haven't really seen any that I know of in the younger age group. So that is a kind of positive finding. The symptoms are, predominantly chest pain. It's often very severe, but it is transient and it almost always occurs after the second dose of the mRNA vaccine. It's associated with a troponin leak, which indicates myocardial injury. There's almost always ECG changes. And in our center and in most centers, we do an acute cardiac magnetic resonance imaging that show myocardial edema and late gadolinium uptake, implying some scarring or fibrosis process is going on. Since most of that we saw back in April or May when these teenagers had run out to get their vaccine. So we've been able to get follow-up cardiac magnetic resonance 3 to 4 months after those initial abnormalities were noted. And in the majority of those patients, we still see persistent abnormalities with late gadolinium uptake and even some myocardial fibrosis. The largest reported series, if you want to look for it, was just published a couple weeks ago in Circulation. That was from the Pediatric Heart Network. We at Seattle Children's contributed these 27 cases to a total of 140 cases in multiple centers throughout the United States. And that's a good summary of what happens with the vaccine myocarditis. If you go to the next slide. This is just to show what happens with age and sex. So if you go to the older age groups, the myocarditis is fairly rare. And it seemed to increase with decreasing age, particularly in males and in young males, 18 to 29, and in adolescent males, 6 to 17 years old. So that's why we were a little bit fearful what was going to happen in the even younger age group. So that 6 to 17 is that's only because that's how the state reports it, but that everyone in that group is 12 to 17. So we don't have the data yet for the 6 to 11-year-olds. But so far, so good. We really haven't been surrounded by myocarditis cases as some of us feared might happen. And if you go to the next slide. So in summary, there's a theoretical risk of increased severity in children and adults with congenital heart disease. For adults, at least, there are specific factors such as pulmonary hypertension, cyanosis that do lead to increased risk. In children, case hospitalization and death is very low. MISC results in ICU hospitalization. So far, it's been pretty rare in children with congenital heart disease. Vaccine effectiveness in children for preventing severe disease is difficult to assess, as their hospitalization and death rate is very low. Myocarditis or pericarditis is rare. For an adolescent boy, it's about 1 in 5,000. And so far, we have no concrete reports in the 5 to 11-year-old age group. And I'll stop there. I don't know if people want to ask any questions.
Thanks so much. That was really informative. Really appreciate it. Do you, when your patients come in for their clinic appointments, do you talk to them about the vaccine? And if so, are you able to, or what are the most frequent questions, I guess, you get when you talk with your patients about it?
Well, there's several populations. So congenital heart disease patients, the theoretical risk is there, and depending on what other comorbidity factors, I always recommend that they get the vaccination. Because of the hyperimmune response, I have a pretty large Kawasaki disease clinic. And I'm not sure what to tell them because we presume that the mechanism of myocarditis is related to a hyperimmune response, something against the heart in patients who are susceptible to having that type of hyperimmune response. Obviously, the Kawasaki patients are. I have told some parents, and this also is with Kawasaki, that they might want to wait a little bit to make sure that we're not seeing in the younger children the same type of myocarditis reaction. But I try to give them the information and let them know that whatever they decide, it's their family's decision. If you're in an area that's endemic and there's really high rate of COVID, and we do have particular areas like that in Washington State, like the Yakima area, that they probably should go get vaccinated regardless because the risk of myocarditis is pretty low. We do have a database in Kawasaki disease patients, and so far we have about 20 that I know of got vaccinated, a few with the second dose, and everything looks pretty good so far. I will support a family if they say they just want to wait a little bit.
Thank you. Aaron put in the chat box, are you seeing any increase in myocarditis after boosters in teenagers now that the boosters have been expanded to that age group?
No, as I said before, we've had a few calls, some kids with some mild transient chest pain,